Today we are going to discuss about hospital-acquired pneumonia, healthcare-associated pneumonia, ventilator-associated pneumonia. Definitions of hospital, ventilator, and healthcare-associated pneumonia. Pneumonia that occurs 48 hours or more after admission and did not appear to be intubated at the time of admission is called hospital-acquired pneumonia. Ventilator-associated, a type of hospital-acquired pneumonia appearing after 48 to 72 hours after intubation. Healthcare-associated pneumonia, non-hospital patient with healthcare contact, like IV therapy, wound care, chemotherapy within 30 days, nursing or long-term care facilities. Hospitalization greater than 2 days or more in past 90 days. Attendance at hospital or hemodialysis within 30 days. Healthcare-associated pneumonia. Previously, it is not a pneumonia. It is added as a category of pneumonia in 2005 according to American Thoracic Society guidelines as an increased risk for patients who may have been exposed to multi-drug resistant pathogens from community centers. Principles for management of hospital-acquired pneumonia, ventilator-acquired pneumonia, healthcare-associated pneumonia. Avoid untreated or inadequately treated HAP, VAP, or HCAP. Failure to do so is a consistent factor associated with increased mortality. Recognize variability of bacteriology from one hospital to another, one department from another, and one time period to another. Avoid overdose of antibiotic by focusing on accurate diagnosis, tailoring therapy, and limit duration of therapy to the minimal effective period. Apply prevention strategies aimed at modifying risk factors. Epidemic. Hospital-acquired pneumonia is the second most common nosocomial infection in US. HAP increased hospital stay by average of 7 to 9 days per patient. Estimated occurrence of 5 to 10 cases per 1,000 hospital admissions. HAP accounts for 25% of all ICU infections and more than 50% of antibiotics prescribed. Early onset of HAP and VAP, first 4 days, carries a better prognosis with better diagnosis. Patients with hospitalization or prior antibiotic use within last 90 days should be treated as late onset HAP or VAP due to risk of multi-drug resistance bacteria. Late onset of HAP and VAP, which is more than 5 days, results in multi-drug resistant pathogens and increasing morbidity and mortality. HAP-associated mortality remains leading cause of death among hospital-acquired infections. Estimated is 20 to 50%. Mortality of HAP is 30 to 70%, but may be due to underlying disease rather than pneumonia. There will be worse outcomes in patients with bacteremia, especially Pseudomonas acinetobacter, rather than surgical illness or ineffective antibiotic therapy. Etiology of HAP, VAP, and HCAP. Aerobic gram-negative bacteria, which includes Pseudomonas, E. coli, Klebsiella, and Acinetobacter. Gram-positive bacteria which causes HAP, VAP, are Staphylococcus aureus, and 50% ICU due to medicine-resistant Staph aureus. More common in patients with diabetes, head trauma, those hospitalized in ICU. And some commensals are virulent group of streptococci, coagulase-negative staphylococci, Neisseria species, and Corynebacteria may be relevant in mostly immunocompromised patients. In special circumstances, HAP involving anaerobic organisms may follow aspiration in non-intubated patients. Patients who have used non-invasive posture pressure ventilation. HCAP in elderly patients of long-term care facilities have pathogens that more closely resemble late onset HAP and VAP. Pathogenesis of HAP, VAP, and HCAP. Number and virulence of organisms entering the lower respiratory tract and the response to the host. Microaspiration of organisms which have colonized the upper respiratory or gastrointestinal tract. Hospitalization of patients tend to become colonized with organisms in hospital environment within 48 hours. Common mechanisms include mechanical ventilation, routine nursing care, lack of hand washing of all hospital personnel. Disease state also play important role in alteration in gastric pH due to illness, certain medications, malnutrition and supplemental feedings. Multi-drug resistance. Causes of multi-drug resistance HAP, VAP and HCAP. Gram-negative bacilli, multi-drug resistance like resistance to at least 2 to 8 antibiotics that are usually used to treat common infections. Pan resistance, which means gram-negative organisms resistance to cephalosporins, beta-lactams and fluoroquinolones. Common pathogens I have already discussed. Aerobic gram-negative bacteria, common are E. coli, Klebsiella, Pseudomonas, Acinetobacter, Enterobacter. Gram-positive are Staph aureus, especially MRSA and MMSA. Nosocomial pneumonia seen in immunocompromised patients, which include virus and fungal infections. Multi-drug resistant Pseudomonas, most common MDR gram-negative causing HAP and VAP, increasing resistance to piperacillin, ceftazidime, cefepime, imipenem and meropenem. Currently, some MDR isolates of Pseudomonas are susceptible to only polyleucine B. They are sensitive to polyleucine B. Multi-drug resistance to Klebsiella, Enterobacter and Serratia. Klebsiella are resistant to ampicillin and can acquire resistance to cephalosporins, azithromycin and by producing extended spectrum beta-lactamase. Extended spectrum beta-lactamase remains susceptible to carbapenems. Citrobacter and Serratia may also produce ESBL. Acinetobacter species which are responsible for MDR, VAP and HAP. Acinetobacter has recently showed increased resistance to common antimicrobials. More than 85% are susceptible to carbapenems, but resistance is increasing. Sulbactam has become an alternative therapy. Maltophilia and Capacia are common colonizers of the respiratory tract, uniformly resistant to carbapenems, usually susceptible to bacitracin, pimentin and fluoroquinolone. Capacia is also usually susceptible to ceftazidime and carbapenems. Methicillin resistant Staph aureus. If there is methicillin resistant Staph aureus, they will be sensitive to vancomycin and linezolid. Multi-drug resistant Streptococcus pneumonia and Haemophilus influenza, most likely associated with early onset HAP in patients without other risk factors, frequently community acquired. Many strains of Streptococcus pneumonia are penicillin resistant due to penicillin binding proteins. These can also be resistant to cephalosporins, macrolides, tetracyclines and clindamycin. Fungal pathogens, most common is Candida and Aspergillus. Most commonly in seen most commonly in organ transplant or immunocompromised neutropenic patients. Aspergillus contaminated air ducts or local construction. Candida is common airway colonizer and rarely requires treatment. Viral pathogens, low incidence in immunocompetent host. Influenza A is the most common viral cause of HAP and HCAP in adults. Risk for secondary bacterial infections, superinfections. Streptococcus, Haemophilus influenza, Group A Streptococcus, Staph aureus. VAP and HAP. Leading infectious causes of VAP include MSSA, MRSA, Pseudomonas and Maltophilia, Acinetobacter. Pseudomonas, Maltophilia, Acinetobacter are gram negative. MRSA is gram positive. Healthcare associated pneumonia. Most patients included in these studies were recently hospitalized or had been transferred from nursing home. These are studies. Risk factors for multi-drug resistance. Host risk factors include treatment with antibiotics within preceding 90 days, current hospitalization of greater than 4 days, high frequency of antibiotic resistance in community or hospital unit, immunosuppressive disease or therapy. Specific risk factors for MDR pathogens associated with healthcare associated pneumonia. Hospitalization for greater than 2 days within the last 90 days or severe illness, antibiotic therapy in past 6 months, poor functional status as defined by AOL score and immunosuppression. Modifiable risk factors: strict infection control, alcohol-based hand disinfection, microbiological surveillance with timely data on local multi-drug resistant pathogens, removal of invasive devices, programs to reduce or alter antibiotic prescribing practices. Modifiable risk factors include intubation and mechanical ventilation increase the risk of HAP within greater than 6 to 21 fold. Non-invasive positive pressure ventilation data shows used to avoid reintubation may be associated with more incidence of HAP. Sedation protocols to accelerate ventilator weaning. Reintubation increases risk of ventilator associated pneumonia. Gastric and tracheal tubes rather than nasal may reduce incidence of sinusitis and subsequent LRTI. Limiting use of sedative and paralytic agents that depress cough. Keep endotracheal cuff to greater than 20 centimeters of H2. Modifiable risk factors: aspiration, body position and enteral feeding. Modulation of colonization, oral antiseptics and antibiotics. Oropharyngeal colonization is independent risk factor for ICU acquired HAP by entering gram-negative bacteria and pseudomonas. Oral antiseptics like chlorhexidine significantly reduce rates of nosocomial infection in post-operative patients and routinely used in ICU as part of oral care. Decontamination for digestive tract using non-absorbable antibiotics either orally or through GT has shown benefit in reducing HAP or VAP. However, not widely used in US due to risk for drug resistance. Bleeding prophylaxis and glucose control. H2 blockers have shown increased risk for VAP versus benefit for stress bleeding should be considered. Diagnosis: difficult because clinical findings are non-specific. According to ADS guidelines on the management of adults with HAP, VAP and HCAP, it does not provide specific criteria. Symptoms are fever, purulent sputum, leukocytosis with a decline in oxygenation, hypoxia. Radiographic findings plus 2 of the clinical findings are specific for sensitive and specific for pneumonia. And LRTI needs to be collected from LRTI culture needs to be collected from all patients before antibiotic therapy, but collection of all culture should not delay the initiation of therapy in critical ill patients. Semi-quantitative or quantitative culture data can be used for management of patients with HAP. Lower respiratory tract cultures from bronchoscopy or tracheal aspirate mostly applies to VAP. Quantitative cultures increase specificity of diagnosis of HAP. Negative lower respiratory tract cultures can be used to stop antibiotic therapy in a patient who has cultures obtained in absence of antibiotic change in past 72 hours. Chest X-ray, comprehensive medical history. How to diagnose? By taking medical history, chest X-ray to identify infiltrates and possible complications such as effusion or cavitation, and arterial oxygenation by doing ABG. Blood cultures, patient with moderate or severe pleural effusion should undergo thoracocentesis to rule out empyema or parapneumonic effusions. Lower respiratory tract samples, sputum culture, bronchoscopy or tracheal aspirate. Sterile culture of respiratory secretions in absence of new antibiotics in the past 72 hours virtually rules out presence of bacterial pneumonias like viral and legionella. This is the algorithm for diagnosing HAP, VAP and HCAP. First, obtain lower respiratory tract for culture, quantitative and qualitative and microscopy. Unless there is both a low clinical suspicion for pneumonia and negative microscopy of lower respiratory tract sample, begin empirical antimicrobial therapy using algorithm. Check cultures and assessment clinical response by checking temperature, WBC, chest X-ray, oxygenation, purulent sputum, hemodynamic changes and organ function. Antibiotic treatment of HAP. Empiric antibiotic therapy for HAP. HAP, VAP or HCAP, late onset are more risk for multi-drug resistance. Early onset is safe. These are the potential pathogens and recommended antibiotics. Assessment of non-responders. Wrong organism, wrong diagnosis and complications. Wrong organism, which is drug-resistant pathogens, inadequate antimicrobial therapy. Wrong diagnosis, when diagnosis is wrong, atelectasis, pulmonary embolism, ARDS, pulmonary hemorrhage, underlying disease or neoplasm. Complications of hospital-acquired pneumonia or VAP or HCAP includes empyema or lung abscess and Clostridium difficile colitis, infections and fever.